Hello. Now we will discuss about diabetes insipidus. Diabetes insipidus is a condition in which there is increased water losses in the urine, that is polyuria, due to absent or decreased or altered activity of antidiuretic hormone, which is also known as arginine vasopressin. So there will be increased losses of water in the urine, polyuria, due to absent or decreased or altered activity of ADH. ADH is an hormone produced in hypothalamic nuclei and secreted from the posterior pituitary. There are two types of diabetes insipidus: central diabetes insipidus and nephrogenic diabetes insipidus. Central diabetes insipidus is the problem in the hypothalamus or pituitary, due to which there is absent or decreased antidiuretic hormone production or secretion. Nephrogenic diabetes insipidus, here the ADH secretion and production is normal, but the ADH receptors on the kidney are absent or altered. Due to this, though the ADH is normal in the body, it cannot act normally because of the absence of ADH receptors on the kidney. It is of two types, congenital and acquired. Acquired is seen in hypercalcemia, hypokalemia and urethral obstruction. Diagnosis: this is the etiology of diabetes insipidus. Diagnosis: normally the urine osmolality is 500 to 800 milliosmoles per kg, but in diabetes insipidus the urine osmolality is very less because lots of water is excreting from in the urine, so urine osmolality will be very less than 300 milliosmoles per kg. How to differentiate between central and nephrogenic DI? After ADH, that is desmopressin acetate, which is the synthetic form of ADH supplementation, the urine osmolality increases in central diabetes insipidus, because in central diabetes insipidus the pathology is decreased or absent ADH. If you supplement with ADH or synthetic ADH, then the urine osmolality will increase because the water excretion will be decreased. Whereas in nephrogenic diabetes insipidus, if you supplement with ADH also, there is no reduction, there is no increase in urine osmolality. So this is a test to differentiate between central and nephrogenic diabetes insipidus, that is to supplement with desmopressin acetate. The urine osmolality increases in central diabetes insipidus, whereas there is no change in urine osmolality. It remains less than 300 milliosmoles in nephrogenic diabetes insipidus. Next, the complications. Complications are dehydration due to more water losses from the body and hypernatremia. Next, the treatment. The treatment of central diabetes insipidus is supplementation of ADH or its synthetic form and increased water intake. Because more water is lost in the urine, the increased fluid intake should be encouraged and taken. On the treatment of nephrogenic diabetes insipidus, thiazide diuretics. You might be confusing. Already the water and fluid is lost more in the urine. If you give diuretics, there will be more loss of water in the urine. But why thiazide diuretics are used? Because these will increase the sodium excretion from the tubules, which activates aldosterone. When aldosterone is activated, both sodium and water retention will occur. Sodium and water are absorbed from the kidneys. So by this mechanism, this is called paroxysmal effect. By this mechanism, the water is absorbed into the body along with sodium. So for treatment of nephrogenic DI, we can use thiazide diuretics. Indomethacin is also effective. Here also you should take increased water. Fluid intake. In acquired forms like hypercalcemia, hypokalemia and urethral obstruction, acquired causes should be eliminated to treat the acquired causes of nephrogenic diabetes insipidus. So this is the about diabetic insipidus. If you have any doubts, please comment. If you like the video, please like and subscribe to my channel. Thank you very much.